Hello, happy Teach Me Tuesday. My name is Lisa Houston, and I'm a clinical nurse educator in the NICU, coming at you with a weekly topic. And this week, we've started the month of April, so kind of have a small theme going, not as exciting as our new beginnings in March. But today we are going to talk about congenital diaphragmatic hernia, what that means, how it affects the baby, and what kind of the outcomes are and what to expect as a bedside NICU nurse. So, congenital diaphragmatic hernia is a condition that's present in birth and known about in utero. There's an opening in the diaphragm that allows abdominal organs to come up into the area of the chest cavity where the lungs should be. So it can vary in severity. It depends on how many organs come up, how big the hole is, which side of the diaphragm it is on, and generally how much pulmonary hypoplasia it causes. Babies born with CDH really can have extreme breathing problems after they are born that can be life-threatening. They can also go into PPHN, which we'll touch on briefly and maybe is a future topic, so stay tuned for that. But the CDHs are some of our sickest babies sometimes. And so, when people think, oh, you work in the NICU, you take care of these teeny tiny babies all the time, which is true. We do take care of teeny tiny babies, but we also take care of some of these big term babies, such as those born with CDH. So let's kind of talk about what this is. So when you think about the left side, so you're looking at the left side of the baby, that is the most common place for CDH to be. And I think, when we think about that, you can think that we already have a sphincter there. And so the diaphragm maybe just hasn't closed tight enough. And so it creates this hole or an opening. Now, again, depending on the size of that, it is unusual for the liver to be involved in a left-sided congenital diaphragmatic hernia. But it can be, and that is usually really when it's really severe. But for the most part, you're going to see these intestines come up and kind of encircle the area where your left lung should be growing. As we know, based on the lobes of our heart, we already have two lobes there. And so because of the lobes of our heart, the lobes of our lungs, we have two there, and it's already kind of being compressed from the heart. So then now we have these intestines, maybe our stomach, our spleen, all those other organs that have come up there, and then rarely our liver. If it's a right-sided CDH, it's more likely, obviously, to have the liver up there. And with the liver involved, the liver being this dense organ, it's very difficult for that right lung to grow and mature. And so those babies can also be very severe. It is just that it is more unlikely. Recently, I have seen a right-sided CDH, but it was pretty small, and they actually couldn't really tell. We had to do a couple of abdominal ultrasounds to see, was that a CDH? That was kind of this shadow that was showing up on x-ray, and it was, in fact, a little herniation, and just a little bit of the liver had gone up in there. But if you have a big one on the right side, those are going to be very difficult because of where the liver is. So let's talk about the severity. On the top here, this is again from Cincinnati Children's. I love Cincinnati Children's website, pretty much right up there with CHOP and then Lucille Packard are my favorite, really where they go into kind of what we're seeing here. So babies with moderate to severe, which are going to be down here, right, are likely going to need ECMO or other treatments for their PPHN. But let's start with this mild. In this mild, you can see that the intestines have come up into this little hole. The intestines are up here, and this pink area is the lung. You can see how small and underdeveloped that left lung is due to this left-sided CDH. So even in mild cases, it can be pretty severe of what's happened to that left lung. When we come down to a moderate, you can see that part of the liver has come up through that herniation. So I've pointed out our liver involvement here. Whereas in severe, you can see that so much of the liver has come up that our heart is severely shifted over. So not only do we barely have a visible left lung, our right lung also has severe hypoplasia. So as you can see, it is going to be very difficult to oxygenate and ventilate a baby who is basically underdeveloped in both of their lungs. So again, with mild, you can see this little pink, we still have some amount of our left lung. In moderate, we have even less. And then in severe, not only is the left lung not really visible, but our right lung is also underdeveloped. So our lungs have to be filled with fluids in order for them to grow and mature in utero. So the larger the hernia, the more intestines and abdominal organs are in the lung space. So then if the liver is involved, there's this more severe outcomes because of how dense the liver is. The density of this organ makes it really difficult for the lung to try to grow and expand against it. I've mentioned before, and I'll mention it again today, that I would take a 24-weeker with a great fluid level and who goes into spontaneous, labor, and the mom has the baby, over an undergrown 27-weeker with low fluid or oligohydramnios, because those babies' lungs are going to be in a much worse condition than a 24-weeker who has had fluid to help them grow. So this ability to not have fluid in the lung has caused hypoplasia, and they can be severely affected. So this most likely is going to lead to PPHN. So PPHN is persistent pulmonary hypertension. And what you need to think about is when you think of hypertension, you kind of think of this clogging of the arteries and the vessels that are moving blood around. So you need to think about those vessels specifically in the lungs. So this is pulmonary hypertension, and that can be from the pulmonary hypoplasia, the vascular abnormalities, hypoxemia, acidosis, and your mismatch with your ventilation. So just thinking about all that kind of coming together and how severe these can be and how sick these babies are. The kids with severe CDHs are some of our sickest babies that we will take care of in the NICU. So when you think about surgical interventions, it feels like, oh yeah, we're just going to close up this flap. And sometimes it is a small hole that can be closed simply with surgery immediately after birth, a few days after. If it's a small one where the surgeon's just going to move the organs back down and kind of sew it closed. But for larger babies, they may need a Gore-Tex patch or a muscle flap to completely close off that herniation or that hole in the diaphragm. That is going to be a more extensive surgery, and it is going to have a lot involved there. And that baby will have more follow-up. Both babies are going to have follow-up, but the baby with the severe will have more follow-up. So for you as the bedside nurse, what are going to be some key steps for you on admission? So there's 3 things that we really think about, and that's going to be gastric decompression, ventilation, and urgent line placement. So the reason that we need to decompress, so anytime that a baby is going to require PPV or support, so you can imagine if we have pulmonary hypoplasia, the baby is going to need some amount of ventilation. So not only that, but we still have fluids in our GI tract from, they kind of have fluids in there. Think about your bile and all of that. We're going to want to get all of that out so that we can make the intestines as small as possible so that we can do that surgery and have them move down. Also going to make them as small as possible so that the lungs can expand for the ventilation. So that can be done with a Salem sump pump or a Plogel tube, some tube that's going to do intermittent suction at about 40 millimeters of mercury every, it's 5 seconds on, 8 seconds off, 5 seconds on, 8 seconds off to get the fluid and air out of there. I remember working with a surgeon once who was like, when you go to put your Rapogel in, you really need to think about you've got to put it in much further than you would anticipate, because the body, the typical measurement of, nose to tragus to xiphoid process, or just to xiphoid process plus 2, is where we would anticipate our stomach being. But now that everything is displaced, you've really got to kind of put it in there, look at your x-ray, see where it is. Making sure that you're set to your low intermittent suction and watching for what is coming out in your trap. Ventilation is going to be important because these babies really can't be on CPAP or NIMV because that pressure is not going to be directed right into their lungs. It is going to go into, again, their stomach, into their intestines, which is going to cause inflation, again, putting pressure on the lungs. So we're going to get them ventilated, get an ET tube in, get breathing for them so that that pressure, the air, all that is going to go straight into their lungs, and we don't have to worry about extra air happening in their gut. And then we're going to want urgent line placement. These babies are at risk for lots of issues, especially blood pressure related, PPHN, fluid imbalances. So we need to get lines in so that we can give them appropriate medications right away, whether that is any sort of pressors, whether it's going to be Presidex, whether we're going to need to also sedate them so that the ventilator can work for them, either with pain medications or a sedative such as a paralyzer. All of those are going to be super important, so we need to make sure we get those lines and have someone ready for line insertion right away. When we think of long-term outcomes, again, we just need to come back to the severity of the underdevelopment of the lungs and that blood vessel narrowing from the PPHN. This is also going to contribute to any amount of chronic lung disease, the more long they've been on support, all of those things. These babies are at risk for neurological problems. If you think about the decrease in circulating oxygen in the baby from the poorly developed lungs, less oxygen anywhere is going to be less oxygen to the brain. They can have muscle conditions, airway diseases, hearing loss, seizures, and developmental delays, all contributed from their time with less oxygen or from just being from prolonged hospitalization. So the more severe the CDH, the longer the long-term outcomes are going to be, and the more intense and follow-up it's going to be. As I was working on this PowerPoint, this slide deck for the week, I was also noticing that the Incubator podcast had someone on there who was talking about this fetoscopic endoluminal tracheal occlusion, or FETO, and research that they were doing on rats and mice, and how, if you watch the video, which you can find, I found it on Cincinnati Children's website. I believe CHOP has one as well, where they go in and they actually put kind of like an occlusion into the lungs so that the fluid that the baby has already gotten in their lungs actually stays in there. So it's like a tracheal occlusion so that the fluid's not going to come back out, so that the lungs have a chance of not having such severe hypoplasia. And I did not know about this. You can continue to learn 20 years in. It was pretty exciting. And that's an in utero surgery. Fascinating. So upon diagnosis, we need to make sure that our families know that around 34 weeks, the mother or baby needs to be close to her delivering hospital, definitely close to the hospital that she can get the support she needs in. Increased awareness about the need for ECMO, ventilation to treat PPHN, to support the baby immediately following birth and the days after. For education on the surgical procedures and what long-term follow-up is going to look like depending on the severity for their baby. I will link the podcast on my Instagram page, but really it's fascinating to hear all of the research that's going on, kind of how can we try to prevent PPHN and how can we prevent pulmonary hypoplasia. So to recap, when thinking about CDH, we really need to think about the severity. So remember, the most common is going to be the left side. So that's the left side of the baby, where your stomach is, where your gastroesophageal sphincter is. So you kind of already have this little hole. Mild is just going to be some of the intestines and stomach up in there. You can still see part of the lung. There's still some lung development. Moderate is when maybe part of the liver has come in. The less lung is visible. There's going to be a more severe degree of pulmonary hypoplasia. And severe is when there's a good portion of the liver in there that has now caused the heart to shift, which is in turn putting pressure on the right lung, and the right lung is going to have a hypoplasia. Your right-sided CDH is going to be more rare. But again, the more liver that gets up there, the liver is a really hard organ for kind of those lungs to grow against. If you think about the lungs attempting to fill with fluid in utero and continue to grow against the intestines in the stomach, you can see it's a little bit more pliable and the lungs may have a better opportunity. But when they're pushing against this dense liver, there's just not a lot of room for expansion. I kind of think of the intestines on the left side as like this accordion, and there might be room for the intestines to be squished a little as the lungs grow. But the liver is not that generous, and it's not going to allow for that. So knowing where it is, the degree of severity, what the surgical outcomes are going to be, how quickly we can get surgery done so that we can get the chest cleared of all of those abdominal organs so that the lungs can continue to grow. Early diagnosis and treatment in experienced facilities is going to be key to long-term prognosis. So thank you for joining me on this Tuesday for this week's Teach Me Tuesday. I hope to see you again next week. And of course, please comment any questions or any topics you would like for me to cover in future weeks. And I will see you back here next week where we dig into something we were talking about today. Maybe you heard a little sneak peek about that. But have a great week and let me know if you have any questions.